So, and this is what we have. There are different treatments. The question is that the life expectancy, as you see, is increasing. And of course, bladder cancer will increase just because of age, okay? It's like prostate cancer. You get older, you get more prostate cancer. Bladder cancer is the same. Even smoking is there, no doubt. Passive smoking, even sometimes patients say, no, but I give up smoking 20 years ago. It doesn't matter. You smoke for 20 years as well. So this is already the damage was done. So it's there, it's increasing, and we have to know it. I will talk about different aspects a little bit. Where is the future in urology, in bladder cancer? I hope to decrease surgery, okay? Less TURs, less cystectomies, less invasive processes. But we need also pharma to evolve, okay, and technology. In non-muscle invasive bladder cancer, for example, this was an 88-year-old woman with hematuria. And you see, I don't know if you see the tumor in the bladder. It was a very big tumor. Okay. And they say, well, 80-year-old, well, she was bleeding. Okay, let's go and operate. And it took me 2 hours. I was a little bit tired at the end. Home in 3 days and was a T1 disease. So I put BCG, and the lady now is 91, coming to my office every 6 months. Hey, doctor, I'm doing fine. So had BCG, and she's doing fine. So TUR still is there, but has to be done a good TUR, and this is important. And just to show, technology has evolved, but there are simple things that urologists know that we, oops, has moved. I don't know why. I will not touch. So we operate, this is a tumor. I suppose you have seen a little bit with how we operate tumors. There are different ways. And this, what I'm doing is what we call en bloc resection. Instead of cutting the tumor and send it into pieces, you can cut it in block and send it in block to the pathologist. For the pathologist, it's better in order to interpret the staging, okay? And probably there are less cells in the bladder and less recurrences, but this has to be demonstrated. But we urologists have to improve. We've done TURs all our lives. Probably in certain aspects, we have to do now move to en bloc resection. And these are, we are talking about this to the urologist. En bloc resection, there's a list of trials that if you see when there is an E in front of TUR, mean that it's in favor of en bloc resection. So there are different aspects, but the problem is that each trial has different results. So I think more trials have to be done or more evidence has to be there, but there are certain advantages doing en bloc resection. Better substaging, it looks like less bladder perforation, which is the patient will have the bladder catheter for less days, which is important. And then we'll see if there is less recurrence. And then with the better imaging of the bladder. There are different methodologies. They are not perfect, but probably better. The thing is that there's not too much evidence, but we see better. So it looks like there is a small or better percentage of results, the quality of imaging. And mainly, and we publish that, is in those patients with multifocal disease. Those patients have had a lot of tumors in the bladder. You start resecting and then feel, okay, I think I'm done. You put the PDD and then you see that there still are remaining some small tumors. And these are recurrences at 3 months, but which isn't not enough good TUR at the first TUR. So, and this also has to be improved. And also AI. AI is coming, artificial intelligence now. And for example, they did this study. So AI did better in detecting tumors than 9 urologists. What they did, so just putting into the bladder and having a look and showing to AI. See, is tumor, there is tumor or there is no tumor. So AI detected better the tumors than the human eye. So yeah, the urologist will retire pretty soon. So at least me, because a few more years I'm done. So the thing is that, well, AI will come as well. So, and probably doing better in certain areas. And what about chemoresection? We are doing TURs, and those patients with TA disease, no? low grade that recur and recur and recur. Why not to do chemoresection? Put something into the bladder and the tumor disappears. We have to improve this, and we are working on it. You know the different now the pretzels, no, with the gemcitabine or dafitinib with quite good results. Probably why not? We are putting an installation of 1 hour, 2 hour into the bladder. Why not to put a pretzel that the product is 15 days or 2 or 3 weeks in the bladder, liberating the cytotoxic agent. This is much better. More contact, more concentration, more killing of the cells, more cytolysis. So this is going to be probably the future. You have a recurrence. You put a pretzel, be back in 3 weeks, and we'll remove the pretzel. That's it. Instead of going into the OR and do. So I think this is gonna come. And you see a lot of trials with systemic and local, and we see that the results are improving. The thing is to decide which of these ones is going to be finally in the market, because there are ones incredibly, I would say, with an insultingly price. Okay, so we will see finally what will come down. And for example, erdafitinib has been shown systemic orally to be good, but now with this trial putting erdafitinib into the bladder, probably the results are really, really very good. So I think really this is going to be the future, the chemoresection in all these patients, multiple recurrent, and avoid a lot of TURs. Muscle invasive. Well, you see, the first cystectomy in 1874, Mr. Billroth, the patient died in 14 days. Okay, this was the first cystectomy. In 1923, the mortality rate was 59% in cystectomy. Okay, just 100 years ago. Okay, now it's much better. But still, we have to improve. Those centers that do very few cases per year, they have a higher mortality, a higher morbidity. So this has to be localized in good centers that, and I think it's difficult, but I think in UK, they are doing a good job. Certain countries in the Netherlands as well, that, okay, all the penile tumors go to this center, all the cystectomies will be done in these centers, and then the results are better, and you decrease mortality. So I think this is important. And why not telesurgery? For example, let's say a center that they are very good doing robotic prostate, but they have a few cystectomies per year. Okay, you connect the robot, and someone from a center that do a lot of cystectomies does a cystectomy. That's it. So, and this is coming. Of course, there are some drawbacks, patient trust, potential dehumanization, patient vulnerability. This has to be considered. And also the consent form, legal issues. What happens if there is a complication? The surgeon, it's maybe 1,000 kilometers far from the patient. So it has to be some local to solve the problem. So there are several issues that have to be solved, but clearly with the network evolution, now we have it was the 3G, 4G, 5G, 6G, I don't know how many Gs will come in the future, but finally they will, I don't know. I mean, now it's, the robotic surgery, you can operate from here in 8,000 kilometers, and the movement is just straight, no problem, no delay at all. So you can really do it. The thing also then it's cost, where you put the robot, in which city or where you Jesperg is there. So all these things have to be solved, but why not in the near future? I think in cystectomy, for me, it's quite clear. A center can do robotic prostates, and then the cystectomies are done by someone else with the telesurgery, and that's it. The problem is solved about mortality and morbidity. And the surgery has improved. ERAS protocol, I said before, to prepare the patient better for a cystectomy. Also think about sexual function in patients, women, to do vaginal sparing, the organ sparing, to preserve the uterus, preserve the ovaries, depending on the age and so on, to do a neobladder in women. So all these things can be done, and also in men. So, always I have discussions with people that sometimes come patients to my office saying, no, they told me I have a cystectomy, it means a back and no more sexual function. and I do a neobladder and a nerve sparing, and he has continent, urinating, and potent. So these things can be done. So, and are done. So this has to be, I think patients have to be aware of it and to work on it. If you do a better surgery and control the infection, readmission, and of course you decrease mortality. So radical cystectomy is improving, and we have to work on it, and also about sexual sparing, quality of life for the patients, okay? So the process now, we go now to the treatment. Neoadjuvant chemo is there. It's for years the standard, decreases mortality, okay? You see a difference in the curves. Gemcitabine then has been the high dose, the dose dense MVAC, which looks that it's a little bit better than the classical gemcitabine cisplatinum, and several centers already are doing this. So, and the response rate is a little bit higher. But also we have to know when we give neoadjuvant chemo that the patient arrives to the surgery, a cystectomy, a little bit weaker, let's say, okay? With a little bit of anemia, a little bit of hyperproteinemia. I mean, chemotherapy, I mean, it's not a joke, let's say, okay? So the patients arrive, so these patients after chemo sometimes need more transfusions because the recovery from a surgery is not so good. But still, Clavien-3 complications, you see that are similar. Even if you had neoadjuvant or not, the complications are similar, but it's a different. And why also neoadjuvant chemo? I like this slide of my stamp for urologists in surgical planning. The patient is, okay, you see a patient, say, go do chemo and then be back. And also the patient to, oops, what's happening here? It's moving. Stay here. Okay, thank you. By times also for the patient to be conscious of what's going to happen, and then having a cystectomy, have time to talk or talk to other patients, or to prepare all the protocol and so on. So I think it's good to do it, okay? So in the guidelines, it's clear that cisplatin-based chemotherapy is what has to be offered, okay? And this is the standard. Also, what's happening now, no, this is the adjuvant chemotherapy, post-radical cystectomy. There is less evidence, as you know, in adjuvant chemotherapy, so giving chemotherapy after cystectomy, but is still there. So those patients who have not received chemotherapy before the cystectomy, we give it after cystectomy if they are locally advanced or nodes positive. So I will go through this. And now we have improved, and also we are now moving more to preserve bladders. And it's, again, this was a topic that was several years ago, and now it's a kind of revival of the topic to preserve more bladders. What to do if a patient, there is a complete response in neoadjuvant chemo, no? And there was a small tumor, we do a good resection, we do neoadjuvant chemo, now there is no tumor in the bladder. Well, the problem is to detect that there is no tumor in the bladder. So even if we do a CT scan, an MRI, we do a TUR, we do cytology, and everything is negative, 25% still have tumor remaining. And this is the main problem. 75 not, but 25 yes. So then now there are ongoing trials with immunotherapy in order to improve the results, trying to go in for this, trying to save more bladders with a safe condition for the patient, not to increase mortality. And these are a lot of trials in bladder preservation right now, a lot of trials going. So it's important that also the patients be aware that with all the, now I would say, now finally bladder cancer is in the map. Always talking about breast cancer, breast cancer, breast cancer, breast cancer, everything for breast cancer, then prostate cancer, prostate cancer. And bladder cancer was nothing for 20 years, BCG, and that's it. And cisplatin, gemcitabine. And finally, in the last 10, 15 years, a lot of new products in the bladder systemically, now all the UMAPs, I call the UMAP fever period right now, okay? Because there are hundreds of UMAPs ongoing trials. So we will see finally the possibility to say, wow, using an UMAP plus this and that, we can save a bladder or not, and we will see, because the best bladder is your own bladder, you know, but, oops, sorry, if there is no tumor and it's functioning adequately, okay? This is important. Immunotherapy, as I said, well, there are a lot of trials, but I just put some examples here of some game changers with atezolizumab that, oops, sorry, that was negative, curiously. And then we had the nivolumab was positive. And then I think a good improvement in this, the ctDNA. ctDNA is to detect something in the blood that show us that there is still tumor, tumoral cells in the blood, okay? So you do a TOR and then the ctDNA disappears. Thus, probably there is no tumor. You do chemotherapy and the ctDNA disappears. Probably the tumor is cured. So, and it's more orientative. Until now, we didn't have any marker to know if there is a good response or not, tumor remaining or not. Now there are trials ongoing with ctDNA evaluation, which is gonna be good because it will save a lot of unnecessary chemo. So if everything is negative, ctDNA is negative, no chemo, and then we'll save a lot of problems to the patient and a lot of money, okay? So ctDNA is gonna play a role in the future, and it makes a difference in this trial with atezolizumab, okay? So here you have a nivolumab, a positive trial with Ambassador, now with Pembro also a positive trial. So now recently we had several good trials, positive trials with our friend Tom Pauls with in front of all these trials. And you see that, well, some in primary and disease-free survival, some not in overall survival. So, but there is a mix now of good trials with positive results that probably are going to change the practice. But as it was mentioned by the person from Sweden, no, the thing is about cost of all this and the final positioning of all these drugs, because it's not so easy to decide, okay? And also who's going to pay all this. So you see more and more trials. There is a problem about certain different type of cells. You know, we have different type of cells that some respond better to chemotherapeutic agent or to immunotherapy. And also this has to be taken into account. Even there are not trials really clarifying which has to be used, okay? And now there is a proposal, Lerner presented at ESMO, to use the different type of cells, luminal, basal, and so on, in order to decide a certain treatment and see, compared to a standard treatment, if they are going to do better. So trying to move into molecular staging as well, in order to decide the correct treatment. So if you have this kind of tumor, you better not receiving chemo, or this immunotherapy probably will do better. So this is the next step. Not everybody sees cisplatin gemcitabine and that's it. No, probably. But moving forward to this direction, and Lauren is doing a good job. And here you have even more trials ongoing, new drugs. So the situation is going to change clearly. And here is a schema I like also this is to save pathways, because when the patient has hematuria, and there was, let's say, the hematuria clinic, or how to proceed. And now I see that a lot of places, we have Dr. Panebianco from Italy, we have to do MRI to all our patients, MRI to all the patients. Why? I don't see the reason exactly, you know? It's a kind of, I would say, as I said, the UMAP fever period, no? All the UMAPs. I think now there's also the MRI fever period for the urologist. MRI, since MRI is very good in prostate cancer, clearly, no doubt. In prostate cancer, MRI to really quantify the tumor, see the tumor, PRADS 1, 5, 3, 4, or 5, and to decide the surgery, clear, no doubt. But in MRI, it's, let's say, we'd have nice pictures, but are they useful? This is the question. And it's not clear yet. It's nice, we have a better image, and we are spending more money. Really necessary? That's the question. So for me, and I think it's clearly here, when we see yeah, with ultrasound, you can see a very nice tumor. Oh, sorry, very nice for this talk, for this comment. I'm a urologist, really sorry. We see a tumor. If it's a small tumor, go directly to TOR and that's it. It's not needed an MRI. It's not be useful. This is a big tumor or solid aspect, maybe MRI better. And then to see if it's resectable, completely resectable by TOR, do a TOR, and then non-muscle invasive or muscle invasive. If you are resected completely, you can do a trimodal therapy and preserve the bladder, even if it's muscle invasive. If it's not resectable, very big, extravesical, nodes positive, chemotherapy, just do a cystoscopy, a biopsy in order to have the type of tumor. It's not necessary to do a complete TOR. So we are saving a TOR to the patient. So then we do a cystoscopy, biopsy, and with this, we can start chemo. And then with chemo, depending on the response, we decide. So this is a kind of saving diagram about saving a lot of money with MRIs, with TORs, and so on, and doing also a good job with our patients. So we will see. So this is what is currently set in the guidelines, the AUA and the NCCN. They are quite similar. Not too much variation, still chemotherapy and all the steps, neoadjuvant, adjuvant, before and after cystectomy is there. And right now, apart from all the schema I said, now there are the new drugs coming, the nivolumab in PD-L positive, or atezolizumab, according to ctDNA. So, and durvalumab, not approved yet. The combination of EV-Pembro that was approved, it's approved by the FDA, it's approved by EMA, but now the countries have to decide who's going to pay, okay? One thing is a country with that everything is private, and they pay, that's it. You have a lot of money, you pay, that's it. This is always the same. The one who has a lot of money has a better car than the one I have, I'm sure. So I don't have a Lamborghini, So that's it. So, but still in a country that the government pays, all the population have to consider where to spend the money and to be very precise where to spend the money. As I said before, an example, you may have in a country, I don't know, thousands of patients in a waiting list with a bladder catheter because of BPH, which that surgery cost 2,000 euros. And to treat, these patients are waiting 1 or 2 years with a bladder catheter, not urinating properly. And you spend millions of euros in a treatment in the last 2 years of life of a patient that the majority, sadly, are going to die. So these are political decisions, ethical decisions, patient-oriented decisions that it's difficult unless, and they will talk about the qualities and all this, it's really a real advantage in life. Otherwise, so these are interesting topics. So the future of urothelial carcinoma, well, we have seen with this combination of EV-Pembro that really, wow, there is a prolong of life that we have never seen this curve in you see here, this survival of majority of patients normal curve. Was like this, and now we have survival. So we have now people living 45, 50% at 5 years, which this is really incredible, really good. So we are moving in the right direction, still a lot to do. And well, like AIDS, you remember AIDS, everybody was dying. And now has been converted to a chronic disease. Okay, why not with bladder cancer? If the people that respond, what we see now with all the immunotherapy is that those who respond live for years, incredibly. It was not seen before. So, well, we will see. Maybe this is the future in bladder cancer in several areas. So, a lot of new developments in the last years. Finally, bladder cancer is moving forward. We are really happy. Well, the the group of urologists that we are bladder cancer addicts. I've been working in bladder cancer for only 30 years, and we are really happy. So, and as I said, let's not pretend that things will change if we keep doing the same things, no? So we have to move, we have to change, and, oops, last one. The future is less URBs, less cystectomy, and some more trials. Thank you.